So this morning, I'm excited to introduce Dr. Cécile Viboud, who is a staff scientist for the Fogarty International Center in the National Institute of Health. And she's also part of the multinational influenza seasonal mortality study. Dr. Viboud received an engineering degree in biomedical technologies from the University of Lyon and an MA in public health and Ph.D. in biomathematics from Pierre and Marie Curie University, Paris, France. Her research focuses on the epidemiology and transmission dynamics of viral infections at the interface of public health, big data, and computational modeling. While she has carried out work on a number of emerging infectious diseases like Ebola and MERS, she has extensively investigated the epidemiology of influenza and is one of the foremost experts on its spread. And I realized I wrote down way too many kind of foci of her research for influenza, so I'll just kind of hit a couple of them to give her a little bit more time. So she's definitely expert on the spatio-temporal dynamics of influenza around the country and around the globe, thinking about how the climate, human movement, and behavior patterns impact the epidemiology and evolution of the disease. She's worked hard on understanding novel digital methods for tracking and predicting influenza disease. She's worked on understanding how to make flu forecasts more actionable for communities and policymakers. She's thought a lot about implications of a universal flu vaccine and what that could mean towards evolution and seasonal dynamics. And also, of course, she's also worked on estimating influenza mortality as part of the multinational influenza seasonal mortality study, of course. And on a personal note, one of her, I'm actually not sure. I think it might have been one of her first papers on looking at flu forecasting as using the method of analogs. So it was one of the first papers that I read basically that got me into flu forecasting because I just love the idea. And so it's really incredible idea. And basically in simple terms, if you're trying to predict influenza time series, you can match the most recent few weeks of data with trends from historic epidemics and make predictions based on the subsequent trends in kind of the close matches from historic dynamics. And that was one of the kind of first papers that really got me in flu forecasting. So it's got a soft spot in my heart. As for COVID-19, tons of work really early on assessing trends in the epidemiology of COVID-19 and studied the outbreak progression across China, finding the delays between symptom onset and seeking care before and after January 18, 2020, as the awareness of the outbreak increased. Lots of work on understanding case fatality rates, early and current death tolls of COVID-19 around the globe, looking at doubling time patterns in the early spread, understanding how human behavior and movement and contact patterns have shaped the epidemic trajectory, and of course, a little bit of work on vaccine prioritization. So lots of really fundamental work on COVID-19, and we're really excited to have her here. So with that, I'll let her take it away.
Okay, thanks, Spencer. That was quite a lot, a little scary actually. Yeah, so today I wanted to share some work on mortality actually from COVID-19. Can you hear me well first? Yeah, that sounds good. Okay, great. Yeah, so I mean, it's work we've done comparing both South Africa and the US. I mean, with the Fogarty International Center, so we always like to compare different countries, but we also have a lot of collaborators around the world. And the idea there is it's not transmission modeling, but it's looking at trends data on hospitalization and death and trying to tease out the direct versus indirect impact of COVID-19. And Spencer, you alluded to trends in suicide, for instance, and so that's one of the factors we're interested in. So what we define the direct impact of the virus to be is the direct result of a SARS-CoV-2 infection, and some of those might be tested and detected, especially if you have a lot of testing going on, but some might not be. So for instance, you might have a diabetic patient who gets SARS-CoV-2, but it dies of diabetes, right? But the death was triggered by SARS-CoV-2, and that's very difficult to tease out. And so we need statistical approach to try to get at those impacts. And then we're looking also at the indirect impacts of the pandemic. I'm sorry, it's just background, my neighbor is renovating. And then the indirect impacts of the pandemic is just the impact of interventions and depression and issues with the economy. So you can think of those in two ways. One of those would be negative impacts, so an increase in mortality, for instance. And in particular, because people might avert the healthcare system when they really need it, and we have some evidence that this happened. But there could also be increase in suicides and opioids, and I think I'm going to show you that there is some of that in the US, certainly. But there can also be positive impacts in the sense that we've been on lockdown for a long time, and so there's been a decreased circulation of a lot of pathogens that traditionally cause mortality. Right, so we're trying to tease out those different impacts. So starting with the US, those are our national vital statistics for a few years before the pandemic, and to the right of this graph, you see the 2020 year, and this goes up all the way to the end of December 2020. And we're looking here at different age group, from the youngest age group down to the oldest age group at the bottom. And then the three different columns represent three different jurisdictions, the entire US, New York City, and then California. And this is just to illustrate the heterogeneity both across age group, but also across geography in the US. So a lot has been written about the epidemic in New York City, where you see this very sharp peak and this is all-cause mortality, right? So, and so we see this very sharp peak in March and April of 2021. Our estimate is that the COVID excess death rate, so the excess above a seasonal baseline, that was what we are used to see, is about 3.8 per 1,000. And just for context, in New York City, we have very good data back from 1918, the 1918 flu pandemic, where we can apply exactly the same approach. And the fall wave of 1918 had an impact of 5.3 per 1,000. So higher, but it's really the same order of magnitude. And it is quite mind-blowing if you think that this wave that we had in March, April 2020 was controlled relatively rapidly, right? So this is not the full-blown impact of what COVID-19 could lead to. And then on the flip side, here in California, we have a relatively mild impact of the pandemic, especially in older people. And it's really not until the late months of 2020 that you really see a rise in older people, but more of the impact is seen in younger folks. And here on the left, again, it's for the entire US, where you see three waves, which is the wave that we see in the eastern seaboard, then the wave in the summer in the south of the US, and then it's a very general wave that's widespread in the last few months of 2020. And if you look at the timing of those waves, they're sort of quite synchronous for every age group above 45, but for the 25 to 44 years old, there's sort of a prolonged increase of mortality that's not really related to what you see in other age groups. And there's maybe a little bit going on in the under 25, but not very much. So the idea is to try to piece out each of those waves in different states and in different age group and try to see what's COVID-19 versus what's other things happening during COVID-19.
Cécile, can I ask a quick question about that last graph? Did you calculate the, just as you did for 1918, did you calculate the similar all-cause mortality for the 2017-18 flu season, where you see that peak on in your graphs?
Yeah, so I don't know that I have this here, but we did do that for this paper. So at the scale of the US, COVID-19 is 5 to 6 times that peak. But if you look at specific states, that's different. I mean, New York City, for instance, it's way above that 2017, 2018 peak. But across the US, it's about 5 to 6 times. Right, so I mean, here on the left-hand side, we have an example of the type of approach that we're running for this data. So we are looking here at weekly excess mortality, it's in black. for different states and the US as a whole. And the green curve is a seasonal baseline that includes harmonic term for seasonality. It also includes influenza terms, because we know that in regular flu season, flu affects mortality a lot, as well as time trends. And so what we're saying is we're looking at the period in 2020 here, starting March 1st, and we're saying that everything above the baseline is associated with the pandemic. And because this is here respiratory mortality, everything above the baseline is associated with COVID-19, and I'll show you some data that suggests that this is indeed happening. On the right-hand side here, we're sort of aligning those values of excess mortalities in the different states. So from March to December 2020, against seroprevalence survey from the CDC. So we're taking the latest one that was available when we did this, which was the end of December. And there's a delay between infection and having antibody titers, but there's also a delay between infection and death. So we just align the dates of those things. And what you can see from the slope of this curve, you can estimate the infection fatality rate, which we estimate to be about 0.77% here. And there's a recent review paper of data from different countries that suggests that this is a pretty good estimate. But what's notable is that we have two states that are clear outliers and that have higher IFR, and that those are New York and New Jersey. And so there could be several things going on there. They have a slightly older population, but when we adjust for that, they still show up as outlier. But they did get the epidemic very, very early. And so at a time when management of patients wasn't what it is now, I mean, clearly very little was known at the time. And the other thing is that they had a lot of nursing homes hit early on, and that also tends to have a devastating impact on excess mortality. The other thing is that because they had such big spikes, the healthcare systems was quite overblown for a few weeks, and that might have affected the care of those COVID patients. But what we were really interested in is looking at the impact of COVID-19 on causes of death that are not related to respiratory conditions. So we're looking at here Alzheimer's, cerebrovascular disease, diabetes, heart disease, respiratory illness just as a marker of COVID-19, again, the nice three peaks, and then unnatural deaths, which is also called external death and includes suicide, trauma, injuries, and opioids in the US. So we don't have any more details. They're given to us as aggregated. We'll have more detail later on, but right now this is what we have. But clearly there is a sharp rise in 2020 in those deaths. For the other death, you do see that they tend to be quite synchronous with respiratory illness, especially the first peak is seen in Alzheimer's, heart disease, and diabetes very clearly. The last peak, not so much. And so in the next few slides, what we're trying to do is try to look at the synchronicity between those time series. So saying that if this time series of Alzheimer's, the excess mortality during the pandemic on a weekly basis is correlated with respiratory illness, it is in favor of a direct impact of COVID-19 on Alzheimer's. If there is no correlation, as we will see, for instance, with unnatural death, then it's more about an indirect impact. And we can do this by looking at weekly patterns, but we can also look at it at the state level. So saying in states that have had a lot of COVID-19, do they also see a lot of Alzheimer's, right? And so that would also speak to a direct impact of SARS-CoV-2 on Alzheimer's. So this is just aligning the time series here. So the red line is respiratory mortality. So that's our indicator of COVID-19 intensity every week. And then the other causes in black are the non-COVID related outcomes. And so based on that, what we can do is looking at correlative analysis in the pre-pandemic period and then during the pandemic, and see how correlation, which is a measure of synchronicity, changes over time. So what you're seeing on this graph, the black is sort of the null hypothesis, what's happening in a normal year outside of the pandemic. So we have 40 weeks here of correlation between all-cause mortality and respiratory mortality. So you see it's not zero, right? It's around 0.3, 0.4, and we have different states here. And that's because respiratory mortality is a leading cause of all-cause mortality. So there is always a correlation. But the triangles here represent what happens during the pandemic, and there is a significant rise in correlation or synchronicity, suggesting that quite a bit of the all-cause excess mortality impact is related to COVID-19. We also see significance in Alzheimer and diabetes, although it depends on the state. And then for cancer, it's all over the place. And then there's less of a correlation with cerebrovascular disease. And for unnatural death, if anything, there's less of a correlation than usual. So basically what we can say from this analysis is that the strongest impacts, direct impacts of SARS-CoV-2 will be on Alzheimer and diabetes, as well as all cause. And there will be fewer impacts on the other causes of death. Heart diseases also quite a bit of an association.
So is this, sorry, was that the correlation in the daily counts of those things? Is that?
In the weekly counts,
weekly counts? Okay.
Yeah. So we also did a similar analysis at the state level, again, whether states that have high COVID have also high Alzheimer during the pandemic, and we also see some correlations that sort of align with that in terms of ranking, right? More correlation with Alzheimer and diabetes, and no correlation with cancer or unnatural deaths. So here in this table, we're sort of trying to attribute a direct and indirect impact more explicitly in a model. So it's a simple model where we have the weekly excess mortality for each of these causes as the outcome. And then as a regressor, we have the weekly COVID-19 intensity. And then we have the weekly strength of intervention, because one thought is that perhaps it is the lockdown, it is the intervention that precipitate death, right? Because people are averting the healthcare system, or because their mental health is declining. And so by putting those two things in a model, we can try to tease out which is significant, and then how much of an impact each of those have. And the weekly strength of intervention is based on the Oxford Intervention Index, both at the scale of the US and then at the state level. And what we can see here is that the proportion of data that are directly attributed to COVID-19 here is the highest for all-cause mortality. So of all the total increase in mortality in 2020, 75% is directly due to COVID-19. Then we also see that 30% of Alzheimer and 36% of diabetes can be directly attributed to COVID-19, but not recognized on the death certificate. We do not see any significance of COVID-19 intensity for those other causes of death. And the weekly strength of intervention is not significant anywhere. And here on this column, I'm just indicating the total number of deaths for all of these causes, just to give you an idea. So a lot of deaths from Alzheimer and relatively fewer from some of the other causes, but 33,000 deaths from external causes that we're not used to see. That's not something to sneeze at. And cancer is the only death that seems to be declining, although it's not significant. The confidence intervals are quite large. And we, of course, don't think it's truly a decline in cancer. We think maybe there are some coding issues there. People really dying from cancer, but maybe being listed at COVID-19. And so what's interesting also is that if you try to do the same type of analysis by age group, you see quite different patterns. So let's focus for a second on the right-hand side column here, which is what we get from the model where we have weekly COVID intensity and strength of interventions. Here we're regressing total all-cause mortality, but it's by a different age group. And what we can see is that the direct impact of COVID-19 increases sharply with age group. It is almost 100%, and that includes 100 in the confidence interval in the oldest age group. However, the model cannot attribute anything in the under 44 years of age. Another way to calculate the direct impact of COVID-19 is just to divide the official statistics of COVID-19. So this is any death certificate with a COVID-19 code, and we can divide that by the total excess mortality that we see in this age group, right? And those estimates tend to be quite similar in the older age group, and then in the younger age group, we similar to our modeling approach. But in the younger age group, we see a relatively small impact of COVID-19, 23%, which means that more than three quarters of the mortality impact we see in under 44 years old is indirect impact. And the other very interesting bit there is that when we do the weekly strength of intervention in the model, it is significant, even though COVID-19 is not. And so we can attribute actually more deaths in people under 44 years of age in weeks where we have strongest interventions, so where there's more lockdown. We are unable to say whether it's suicide or opioids or exactly what's happening there or violence, but there is a tight connection with interventions and not so much with COVID-19. Okay, so we see in the US, we see a substantial increase in a number of conditions, but there's variation in what is direct versus indirect impact of COVID-19. Perhaps the most striking finding was this non-negligible impact of the pandemic in young individuals that are not directly tied with COVID-19, but more tied with interventions. And we see a lot of heterogeneity, which I glossed over, in excess mortality pattern across the US. I'm sure this audience is very familiar with this, but it is in a way echoing the heterogeneity we see across Europe and other large regions. And the other interesting thing to think about is what is the impact of a lockdown if there is no COVID? And we have two countries that have been through this, New Zealand and some provinces of Russia, where their lockdown before COVID really became predominant. And the data there suggests that the impact on mortality is null. You see the same mortality that you see in a baseline year if you don't have COVID. So that is interesting. Clearly in the US, we had both, right? And so I think mortality rose due to both of them, and the decline in other pathogens was not enough to balance out that strong increase because of both COVID and lockdown. So just briefly, a little bit of work along the same lines that we're doing with colleagues in South Africa at the National Institute of Communicable Disease, and this is done by Amanda, who was a UT Austin, a student of Lauren before joining NIH as a postdoc. So we're seeing here the circulation of respiratory viruses in South Africa a few years before the pandemic. So this is a temperate country, so their epidemics as a Southern Hemisphere countries are in the middle of the year, early season with RSV, and then slightly later season with flu. And then during COVID-19, there is a really clear depression of influenza, which has not circulated since pretty much March 2020. And there is a temporary depression of RSV, but interestingly, it has picked up again quite rapidly. In the US, as far as I know, we haven't seen this rebound yet of RSV. And then the orange is SARS-CoV-2 peaks that have, I think, been well described in the literature, with the second peak being predominantly associated with the new variant. And so the idea was to look at a new data set of hospitalization in a private sector system that our colleagues in South Africa had access to. So this is a sort of a richer part of the population in South Africa, and look at how total admissions and co-specific admissions change throughout the pandemic, so by age group and cause. So here we're just looking at different age groups. And so the black line are the observations, and the blue line is a seasonal regression model representing baseline admissions if COVID had not been circulating. And so you can see that in younger age group of 0 to 4, and then the next age group, 5 to 19, there is actually a depressed number of respiratory admissions during COVID-19. And then in the older age group, 20 and over, and then over 50, you see the sharp 2 peaks of respiratory admissions, most of which are due to COVID-19. We can also look at it by different provinces, and there is some variability, but they all sort of follow a 2-wave pattern, except perhaps the Northwest province. And so the other thing to note is that after the first wave in Western Cape, there was a sero survey in Cape Town where they found that the attack rates were 40% in the community. Relatively small survey, but supposedly representative. And so our colleagues at NICD were very happy because they thought they had reached, okay, not quite herd immunity, but a large fraction of the population immune. And so they were very surprised to see the arrival of a second wave. And now that we have more information, we actually realize that immunity is quite patchy in South Africa, but I think in a lot of places. And this 40% attack rate is actually, very specific to Cape Town, and other communities, particularly rural places, had seen much less infection. And so it was not surprising to see a rebound. We're also looking at a cohort data to look at risk of reinfection from the first to second wave, and we see very strong, actually, immunity to protection against reinfection despite the new variant. And so just to, don't have too many more slides, but just a few words on looking at other causes of hospitalization here, not COVID, just to look at the overall impact of the pandemic. Overall, we see a sharp decline in non-COVID deaths. So this is all respiratory conditions, but not COVID. This is total admissions in those private hospitals, diabetes, heart disease, trauma, and fractures. And so the different colors represent different age group. Most of the changes here in the chronic conditions, not surprisingly, are seen in adults. And there's quite a large depression in the first few months of the lockdown, which was the strictest months of the lockdown. And then as lockdown relaxed later on in 2020, there was a rebound in those admissions, although it doesn't go back quite to baseline, to pre-pandemic baseline.
Right.
And so, yeah.
Did those pink colors, does that represent the stringency of the lockdown?
Exactly, yeah. Yeah, that's right. So they had a very strong lockdown from first few months, and then it gets lighter, and then as they hit the second wave and heard news about the new variant, they start to reimpose a sort of stricter lockdown. And maybe the one thing to note about the first lockdown, which they're very proud about, is that there was a ban on alcohol, and that could explain the change in trauma and fracture. At least that's what our collaborators would like to see. And so here we're looking at all of those different conditions. I think we have 18 here for hospitalization, and we're looking at weekly changes from baseline. So there tend to be negative changes because everything is depressed during the pandemic as a function of lockdown intensity. And lockdown intensity here is based on the Google Mobility Index, but we've also looked at a lot of other data sets they all correlate. And you can see that in a lot of those conditions, you see that stricter lockdowns lead to stronger depression in admissions for all of those conditions. Interestingly, we also see depression for enteric infectious disease. And so we think that here perhaps it's not a version of the healthcare system as much as depressed circulation of those viruses. But for some of those other conditions, we do think that this is due to people averting the healthcare system, because then they knew there was a lot of COVID there. There is also perhaps suggestion that there's a sort of a threshold effect, where if lockdown intensity is between 0 and 20, it does affect the propensity to seek care, but then any additional lockdown doesn't really change things. And there are also greater decline in some conditions, such as superficial injuries, than other. For instance, cerebral infarction is a little bit messier. So this is where we are with South Africa. I think it's sort of intermediate, because we see that there are decrease in hospital admissions for a number of conditions, including infectious diseases, not COVID, chronic conditions, and trauma. And we think they all sort of have different reasons, but they all correlate with the strength of the lockdown. The question is, what impact does it have on mortality? If people turn away from the system for a diabetic condition, are we going to see those patients later on in mortality data? And South Africa has very good mortality statistics. However, they haven't been able to look at co-specific statistics yet for 2020. But I think that would be really interesting to try to tease out direct versus indirect impacts. And the broader question there is, what is the burden of COVID-19 in Africa? Several papers have been written about this, how we have no data, whether the direct impact is lower than the indirect negative consequences because the population is younger, etc. And so really this balance it remains unclear, and whether we'll also have really good data beyond South Africa remains unclear. But that's very interesting in terms of trying to compare with what's happening in the US. And with this, I will end and will be very happy to take questions.